Okay, hello to everyone. Today we should discuss a very vital topic, especially if to think about nowadays. It is the abdominal trauma. So the questions that we will discuss are objectives, types of abdominal trauma, anatomical regions of abdomen, hospital care and diagnosis, evaluation of patient with blunt or penetrating trauma, and specific organ trauma. So the objectives: to identify the differences in patterns of abdominal trauma based on mechanism of this trauma, describe the anatomical regions of the abdomen, discuss the difference in injury pattern between blunt and penetrating trauma. To identify the signs suggesting retroperitoneal, intraperitoneal, and pelvic injuries, outline the diagnostic and treatment procedures specific to abdominal trauma. So, the majority of abdominal injuries are due to blunt abdominal trauma secondary to high-speed automobile accident. The failure to manage the abdominal injury accounts for majority of preventable deaths following multiple injuries. The primary management of abdominal trauma is determination that an intra-abdominal injury exists and operative intervention is required. Types of the abdominal trauma: it can be blunt abdominal trauma and it can be penetrating. So the difference is if the parietal peritoneum is damaged. So if it will be damaged, it will be penetrating abdominal trauma. And even if there is a wound on abdominal cavity or retroperitoneal space, but during its revision, we will not find any signs that peritoneum, parietal peritoneum is ruptured. So it will not be the penetrating abdominal trauma, and it will have an influence on all our diagnostic and treatment process. It's very important to differentiate this principal two types of trauma, blunt and penetrating. Very important question. The recognition of the mechanism of the injury, whether is penetrating or non-penetrating trauma, is the greatest importance for diagnostic and treatment and workup therapy. The liver, spleen, and kidneys commonly involved in the blunt abdominal injuries. It is so. Anatomical regions of the abdomen that are important to differentiate, to use the proper surgery, to use sometimes specific incision. So these regions are peritoneum, true abdomen, retroperitoneal abdomen, and pelvic abdomen. It's very important to differentiate, to make a decision where to go. Hospital care and diagnosis. And initial management. First, we need to evaluate the patient with blunt or penetrating trauma. The resuscitation and management priorities of patient with major abdominal trauma. The emergency resuscitations, airway, breathing, and circulation with hemorrhage control should be initiated. NGT and Foley catheter. So nasogastric tube and Foley catheter should be inserted. And intravenous catheter as well. Maybe it will be more important than these two, NGT and Foley. So the history. We should, of course, pay attention for anamnesis of the patient, and we need to differentiate maybe some information from the mechanism of trauma will say us that this is blunt or maybe penetrating abdominal trauma. For example, gunshot wound. Yeah, of course, in most of the cases it is penetrating. If it is knife pain, knife wound made by knife, of course, probably it is penetrating. Okay, physical examination. What we need to pay attention for? General physical examinations. Examination of the abdomen. In general physical examination, we need to assess how the patient is sitting. What about his consciousness? What about his compliance? Can he comply at the moment of our inspection or not? It's important. Also, palpation, percussion, auscultation, rectal and vaginal examination. They are also important. All these methods of investigation, they give us some information. Some of them will tell us that we will receive the complete diagnosis after maybe sometimes using just one method of investigation. For example, palpation, and we can determine the broken bone, yeah, and just the palpation, it gives us this information. Simple method and almost complete diagnosis. Of course, we will do an X-ray procedure to determine the line of this broken bone. Some complications, of course, we will do it, but we have a diagnosis just using one physical method of investigation. Okay, diagnostic procedures, blood tests, radiological studies. Most of them are simple, very quick. Plain abdominal X-ray, then the X-ray of thoracic cavity, peritoneal lavage, DPL, yeah, diagnostic peritoneal lavage, ultrasound investigation, CT of abdominal cavity, and peritoneoscopy or diagnostic laparoscopy. So the laparosynthesis. Okay, we will return to the previous slide. So the blood test. For us, it's very important for surgeons to exclude the bleeding, intra-abdominal bleeding. External bleeding, it's no problem to exclude. If the wound bleeds, so it is bleeding. And for abdominal cavity, it is a question. It is always a question. If there is a bleeding in patient, we need to do something. And the blood test. So normally in our everyday work, so the blood test will change in some period of time. So if we will, for example, how to explain it, if we will lose about 2 liters of blood immediately, and immediately we will take the erythrocytes count from our other vein, yeah, for example, if we will imagine. How will the hemoglobin and the erythrocyte level change? It will be no changes, but still we lost 2 liters of blood and nothing changed, because it needs time for our plasma and interstitial fluid mobilize and come inside the vessels to maintain our blood pressure. It will take time. Usually it's about 6 maybe hours, maybe a little more or maybe a little less. It depends, it differs. So if to make a decision only by blood test or excluding bleeding only by blood test, it is a mistake. It is always a mistake to think if the hemoglobin level is normal, there is no internal bleeding. It is a mistake. We need to take into account the time that passed from the period of trauma. You need to remember this to prevent your mistakes in future. Okay, laparocentesis and peritoneal lavage. When we do this, for example, if to imagine that we are working not in a big clinic, we are working on peripheral, maybe some places in some village, for example, big village, but we don't have the laparoscopy. We don't have it. We cannot make any laparoscopy at all. Or we need to discuss laparoscopy needs narcosis, general anesthesia in most of the cases. So, or it needs some special equipment, and it can be lack of this equipment at the moment. So in this case, we perform the laparocentesis of peritoneal lavage. How will we do this? The first we need to do, it is an operation anyway. All the features of operation should be present. So we need to follow the aseptic and antiseptic means to make it correctly. So the first, what we do, we make an incision below the umbilicus. It's better place to insert the trocar with the tube due to anatomical features of abdominal cavity and fixation of the umbilicus to the eponeurosis. So it's easy to take it and to elevate the abdominal wall by holding the umbilicus and the skin using maybe some traps, using some clamps, whatever it can be, but we need to elevate the abdominal wall like this. So this hand goes up, and after the making an incision, we insert the trocar by this angle. It's very important. If we will do like this at 90 degree, we will, of course, damage the organs of abdominal cavity. It will be, first of all, it will be a mental, then the intestines, and so on. So, of course, it should be done under local anesthesia in any patient, even when the patient is unconscious. Anyway, it will be the local anesthesia. Okay, after inserting the trocar, we remove this part and leave this part, and insert through the cannula. We insert the drainage. Firstly, it goes to the liver. We can make a suction from the drainage. In most of the cases, this suction will be negative. Nothing we will receive, and we need to. In our country, we have such a method of investigation, which specificity is about 98%. Okay, not specificity, but diagnostic sensitivity. Yeah, diagnostic sensitivity is about 95-98%, so very sensitive. But the specificity is about 50%, so we will not know which organ bleeds or where is a hole in intestine when we see the peritonitis. So this method, if to translate in English from Russian, it is called the searching catheter, which search the pathology. So the approach is like this, which is described on this picture. So the tube is inserted. Firstly, it goes to the liver, and we will infuse through this sterile tube. We will infuse sterile physiological solution in about 200 ml. Then we will put the catheter below the patient and see which fluid goes out. Normally it will be clean physiological solution. If we will see some mixture for this solution, it can be blood or maybe intestinal contents. So the diagnosis is in our pocket in such a way. It is intra-abdominal bleeding or it is peritonitis after this. Yeah. Okay. Normally we will infuse 200 milliliters of sterile saline in each point. The first is to the liver, second one is to spleen, third one is into right, fourth in left inguinal cavity, inguinal space. Yeah, and the last one is in the catheter should be directed to the urinary bladder or to the pelvic region, and in this fifth spot, the same, we will infuse 200 milliliters of sterile saline, and after that we will again, each time we will move the catheter below the patient and see which fluid discharges from the abdominal cavity. This is the method. After this, normally this tube will stay in abdominal cavity about 48-72 hours. So we will sew the wound and fix with a suture our tube and leave it for inspection, for control for this period of time, 48-72 hours, to control bleeding. Okay, so this is the searching catheter technique. Diagnostic laparoscopy. Here you can see it. How will it look like? The intra-abdominal bleeding in most of the cases. In the left part you see the bleeding in the pelvic region. Here it is not the abdominal trauma, I think so. It is some kind of cyst in okay, it is right maybe what is it? It is the okay, maybe it is the cecum, maybe. In the this part, just the blood. Here you can see blood, and this is a fibrine. Maybe it's peritonitis. Okay, and here you can see it is a part of operation. Here we are under the stomach. It is a stomach, it is a splenic artery. So this is the pancreas, and we see the bleeding from the spleen. And here is the ovary, I think so. It is a rupture of the ovary with the bleeding. Okay. Moving forward. So establishing priorities and indications for surgery. The indication for laparotomy. Signs of peritoneal injury. Unexplained shock. Evisceration of the viscus. And the positive diagnostic lavage. Peritoneal lavage. So now we should discuss specific organs. Trauma is liver and spleen in most of the cases. These organs are traumatized. So, and when we exclude the bleeding from abdominal cavity, the first we need to think about is the spleen and liver, because they are ruptures rather often. So liver trauma, the incidence. The liver is the largest organ, parenchymal organ, in the abdominal cavity and continues to be the most commonly injured organs in all patients with abdominal trauma, blunt or penetrating. About 35 to 45% in blunt abdominal trauma, the liver will be affected. About 40% in stab wound and 30% in gunshot wounds to abdominal cavity. So rather often, every third patient should be excluded with the liver damage. The mechanisms of injury. So hepatic injuries results from direct blows, compression between the lower ribs on the right side and the spine, or sharing at fixed points secondary to deceleration. Any penetrating gunshot stab or shotgun wound on right upper quadrant of the abdominal cavity, abdominal wall, is also likely to cause the hepatic injury. This we need to take into account. So the projection of the liver is upper right quadrant of abdominal cavity. Any damage of this place, any damage should be first of all discussed, and the surgeon or doctor who sees such a patient should exclude the liver damage when he sees such damages on the abdominal cavity, abdominal wall. Clinical manifestation. Diagnosis of hepatic injury is often made at laparotomy in patients presenting with penetrating injuries requiring immediate surgery, or those sustaining blunt trauma who remain in shock or present with abdominal rigidity or intra-abdominal bleeding. Adjuvant diagnostic tests are necessary in the decision-making process to determine whether or not laparotomy is necessary. So we need to decide what to do, to make a surgery or not, to treat conservatively, or the patient will move to operation room. It's very important to use the proper tactics, a proper technique, proper approach for such a patient. So, diagnostic peritoneal lavage has been extremely reliable, 98%, in determining the presence of blood in the peritoneal cavity. Once positive, patient should be taken to the operating room without any delay. CT scan can be used for diagnosing the intraperitoneal injuries in stable patient after blunt trauma. Why stable? Because this method of investigation needs some time, and the patient should be in a CT scan room for some period. It will take about 15 to 20 minutes to receive some information from CT, and this delay can cost a life of the patient. So that's why this investigation is used in stable patient. What does it mean, stable? Stable, first of all, is about the blood pressure, the hemodynamics. So if the patient is hemodynamically stable, then he can be diagnosed properly. We have time in such a situation. So the hemodynamical stability is that sign, that condition that gives us some time. Okay, here you can see the picture where we see the lacerated liver the right side hemathorax. Inside the right lobe of liver, we have such a focus of uh, low density of the liver. Why the density lowers? Due to that contrast remedy does not comes inside this focus. When it happens? When the tissue is ruptured and when hematoma forms inside or outside some kind of organ. So this blood will never, the contrast remedy will never reach this blood. That's why it looks like this. Okay. Okay, patients sustaining significant right lower thoracic, right upper quadrant, and epigastric blood trauma should be suspected of having suffering a hepatic injury. Clinical assessment and abdominal paracentesis and diagnostic peritoneal lavage are most important factors in determining operative intervention. CT scanning may be useful adjuvant in the hemodynamically stable blunt trauma patient. This you need to remember. This you need to remember. So the first is abdominal paracentesis or diagnostic peritoneal lavage. This we need to do. So diagnostic peritoneal lavage I described. In our country it is called the searching catheter, and in Western literature it is the diagnostic peritoneal lavage. Okay, when the patient arrived to emergency room, the initial management of patient should be uniform regardless of organ system injuries. Resuscitation is performed in the standard fashion. If we decide to use non-operative approach, the hepatic injury diagnosed by CT in stable patient is now non-operative approach practiced in many centers. So we can do this when this injury does not influence the uh, hemodynamics. So in this case, we can treat a patient. Sometimes the side effect of this approach is that we can receive the bile peritonitis in such cases. Yes, when the liver is damaged, not only blood is outflows from its parenchyma, also the bile goes out, and it can cause the bile peritonitis. The clinical picture of this bile peritonitis is not so expressed as the usual peritonitis. It will take some period of time, about 2 days, when this bile will be in a big amount and it will cause infectious process, and after that it will be the clinical picture, proper clinical picture. CT criteria for non-operative management include the following: simple hepatic laceration on intrahepatic hematoma, then no evidence of active bleeding, intraperitoneal blood loss more than 250 ml, absence of other intraperitoneal injuries require surgery. Operative approach. Persistent hyperperfusion despite adequate volume replacement suggests ongoing blood loss and mandates immediate operative intervention. So the injury classification, it should be used to surgeons understand each other better. It's very vital to use the classification. So the grades of liver damage: grade 1, simple injuries, non-bleeding; Grade 2, simple injuries managed by superficial suture alone when we sew the parenchyma. Grade 3, major intraparenchymal injury with active bleeding but not requiring inflow occlusion to the Pringle maneuver to control the hemorrhage. Here you can see the Pringle maneuver when we put it is not a ligature, but it's some kind of tourniquet on the liver pedicle, on the artery, vein, and ductus caledocus. So it's rather easy to insert this if the patient was not operated on before and the abdominal cavity is clean without any adhesions. So it's easy to go there when we put, first of all, the finger in the Winslow opening, which is below the hepatoduodenal ligament, just below, and the entrance to the lesser sac. This is how we can come to immediately, almost immediately, and to hold the vessels in our hands between our fingers. And after that we can use, we insert the tourniquet and put it to control the bleeding. We need to remember that it will take 20 minutes before liver dies. So we have only 20 minutes after the placing or after using the Pringle maneuver. Okay, grade 4 of liver damage is extensive intraparenchymal injury with major active bleeding requiring inflow occlusion for hemostatic control. So the Pringle maneuver. Grade 5, juxtahepatic venous injury, injuries to retrohepatic cava or main hepatic veins. The most severe damage, because to close the vena cava back to the liver, we need to come there, and it will need the more wide opening of abdominal cavity. Usually it's like L-like incision or Rio Branco incision when we go midline laparotomy to the umbilicus and then to the right. This incision will give us an opportunity to come to the vein, but it will of course take time, and the bleeding from the hepatic veins, it will need the anastomosis formation, because these veins do not anastomose between themselves, and that's why the cutting of such a vein and make ligation of this vein, it will cost us some part of liver. Okay, all patients undergoing laparotomy for trauma should be explored through midline incision. You see this, the midline incision is most convenient in many cases. Almost all the operations can be performed through such an incision in abdominal cavity, almost, but not for all it gives the proper conditions. I explained to you before that if you go to the backside of the liver, so this incision, it will give not good inspection of the backside. It will be very difficult to operate through the midline, just midline incision. So we need to widen it by additional incision to the right from the umbilicus. So, according to the classification, grade 1 and 2 of liver damage what we will do. The simple injuries can be managed by any one of a variety of methods. Simple suture, electrocautery on hemostatic agents. I'm sorry, okay. Grade through major intraparenchymal injuries with active bleeding can best be managed by finger fracturing the hepatic parenchyma and ligating of repairing replacement the blood vessels and bile ducts under direct vision. Grade 4. Extensive intraparenchymal injuries with major rapid blood loss require occlusion of the portal triad, maybe not the trial, to control the hemorrhage. So it will need the Pringle maneuver. Again, remember that after Pringle maneuver we have only 20 minutes before liver dies. So after 20 minutes we should open, we should remove or loosen our tourniquet. That is how we can save the liver. Okay. Simple techniques includes drainage only of non-bleeding injuries, application of the fibrin glue and sutures, hepatography, and application of surgical agents of hemostasis. Advanced techniques of repair, third and fourth, all performed with Pringle maneuver in place. So the types of surgery that can be applied: extensive hepatography, so just suturing of the wounds. It's just suturing. Simple words, but to do this is not simple. We can rupture additionally the parenchyma of liver. We can sew some viable vessel, for example, and one part of liver will be in necrosis. So it's not easy. Still, we need to remember the anatomical features of liver to make a proper sutures. So, hepatotomy with selective vascular ligation in case of intraparenchymal bleeding. A mental pack also can be used. Resectional debridement with selective vascular ligation, resection of the liver, selective hepatic artery ligation, and perihepatic packing. All these methods can be used. So, hepatography, the most simple, yeah? The sutures that are used, it's the sutures of Jordan and Opit. So, the Opal suture is here, Opit sutures. So, single interrupted sutures. But in our traps, we take the part of parenchyma of former suture, the previous suture. You see this? And it is very important. This gives the hemostasis. And the Jordan sutures, we sew the wound and then cut the liver, cut our traps, the ligatures, and make knots between the neighbor ligatures. Okay, so this is the mental pack of the liver. Previously, the sutures, hemostatic sutures, are applied, but maybe in this situation surgeons observed the additional bleeding from the liver cutting surface, and that's why they inserted the mentum inside of this wound to prevent this bleeding, to press it. Okay, and additional tubes are applied, Jackson Pratt drains, to control the bleeding, to evacuate the blood from the abdominal cavity. Okay, and this is the non-viable portions of liver are debride debrided, and the debridement case is only when bleeding viable hepatic parenchyma is encountered. Okay, that's clear. So we will not ligate everything. It's a mistake. Maybe it's better to make an anastomosis, if we can, of course. So, complications of the liver damage and liver surgery. It can be recurrent bleeding, it can be hematobilia, it can be perihepatic abscess, it can be biliary fistula, it can be intrahepatic hematoma, pulmonary complications, and coagulopathy. Splenic trauma. So, splenic trauma. The spleen remains the most commonly injured organ in patients who have suffered blunt abdominal trauma and is involved frequently in penetrating wounds of the left lower chest and upper abdomen. Management of the injured spleen has changed radically over the past decade. So again, how to think about whether the spleen is damaged or not. We make a general inspection of the patient, and when we see the superficial injuries of skin, maybe ribs, muscles, in the region where spleen lies, so probably it is, besides the superficial damages, it is intraparenchymal or intra-abdominal damage of spleen. So, of course, we need to exclude such a situation because the bleeding from spleen stops by itself not often, rather seldom. It arrests by itself. Okay, now recognized as important immunologic factor as well as reticuloendothelial filter, the spleen. Also, the risk of overwhelming post-splenectomy sepsis or PSS is the greatest in child less than 2 years. Recognition of OPSS has stimulated efforts to conserve the spleen by splenography. So it's not so easy to lose the spleen. You see, sometimes happens this OPSS, the overwhelming post-splenectomy sepsis. It's very difficult to treat pathology. It's very difficult with rather high mortality. That's why on the function of liver, the general imagination was changed. The spleen is commonly injured in patients with blunt abdominal trauma because of its mobility. Most civilian stab wounds and gunshot wounds cause simple lacerations or so injuries. It is of interest that 2% of patients who are undergoing surgery in left upper quadrant, the abdominal can be intra-abdominally, the spleen can be injured. So 2% if to take into account how often does the operations performed each day. Hundreds and hundreds of operations, and 2% is rather high. Okay, pathophysiology and classification. The magnitude of splenic disruption depends on patient's age, injury mechanism, and presence of underlying disease, according to their pathologic anatomy as such. Okay, grade 1 splenic injury. It is subscapular hematoma. Grade 2 subsegmental parenchymal injury. Grade 3, segmental devitalization. Grade 4, polar disruption. Grade 5, shattered or devascularized organ. Subscapular hematoma, or in general hematoma, splenic hematoma, there is such a feature in such hematoma. In our country, it is called the two-stage rupture of spleen, two-stage. How we describe it? At the moment of trauma, some parenchyma ruptures and the bleeding starts. It will arise and arise, but in some cases it will go below the capsule of liver, subcapsule hematoma. Yeah, and will it be bleeding in clinical picture in such situation? No, it will not. It will be some kind of trauma in anamnesis. Maybe we will see some changes on skin and subcutaneous fat in the region of spleen, but we will not see any hemodynamic disturbances. We will not see any changes in blood test in such situation. Yeah, just subcapsular hematoma, just the subcapsular hematoma. And in some period of time, especially if the patient will insist on going home because he feels normally, for example. And what can happen on the next morning when the patient stands up from his bed or maybe go into the toilet or WC, okay, when his intra-abdominal pressure increases, the capsule of spleen ruptures and the bleeding starts. It will not be controlled by formation of subcapsular hematoma because the capsule is ruptured. Nothing will stop it. It will bleed and bleed. It will take maybe few hours till this bleeding stops. And these hours can cause the death of this patient. So, two-stage rupture of liver. You should remember this. Okay, and of course, all this classification is very important. Okay, what we need to do to evaluate the patient properly, to put the proper diagnosis. First of all, we need to take a history of this patient. We need to make the physical examination. We need to make the radiological evaluation. It can be CT, it can be X-ray, plain X-ray of chest cavity, plain abdominal X-ray, angiography, everything we can do, ultrasound. Okay, patient history or anamnesis, rather important. What we should find out from this history? We should find out the mechanism of trauma, the time that passed from the period of trauma. It's very important because if the patient lives for about 24 hours after trauma and then he comes to the hospital, so maybe this trauma was not so life-threatening. And of course it will give us time for proper diagnosis. We will not, of course, immediately operate such a patient. So our scientist, medical scientist Zakharyan, told that good patient's history or good anamnesis gives 50% of proper diagnosis. That's why it's very important to follow this rule, completely to take the anamnesis, completely to take patient's history. Okay, here you can see the rupture of the spleen, the anterior pole. The spleen is enlarged. Why I'm telling like this? Because I see that they use the contrast remedy, and one part of spleen was not contrastized. Yeah, there is no contrast in this part. We can talk about the hematoma formation inside the spleen. Here you can appreciate the artery, splenic artery. Yeah, splenic artery. The same situation, yes. So the treatment. Initial management. Resuscitation, A, B, C, D, E, as usual. Airway, breathing, core, and so on. Non-operative approach. Widely practiced in pediatric trauma. The criteria for non-operative approach. Again, the hemodynamically stable children or adult, those patients without peritoneal finding at any time, those who did not require greater than 2 units of blood. Contraindication for splenic salvage. The patient has protracted hypertension. Undue delay is anticipated in attempting to repair the spleen. The patient has other severe injury, for example, a rupture of liver, or maybe intrathoracic bleeding. But it's again, it is a question if the patient has some other severe injury. So it's a question to remove a spleen or not, if we can conserve it, if we can spare a part of the liver, the part of spleen. So why not to do this? Okay, the types of surgery that can be applied in case of spleen damage. Laparoscopic ligation of spleen artery with spleen salvage, selective emboli of the spleen artery, splenography, and splenectomy. So here you can see the laparoscopic approach in case of bleeding from spleen. In the middle of it, you see the splenic artery. It goes inside the spleen. Okay, the stomach is here, the pancreatic gland is here. So the approach is through the lesser omentum. The approach is through the gastrocolic ligament. The rather convenient approach, access to the abdominal cavity. So it is interesting that if we want to spare the spleen, to leave it, yeah, not to remove, we should make a ligation not close to the spleen. That is how we give an opportunity of blood supply of spleen. So usually it is the splenic artery is mobilized over the body of the pancreas. This is the place where we search it, and through the anastomosis, especially with the pancreatic artery and the anastomosis between the stomach and the spleen, it will be um, rather enough until like this blood supply of spleen in case uh, when we make a ligation higher than the anastomosis of the splenic artery. It will reduce the blood supply, but still the spleen will leave. Okay, also, what methods are available also in case of bleeding from the spleen? The more modern methods of treatment, it is the endovascular procedure, the selective embolization of the spleen artery, of the splenic artery. So it is important to know that it will be, it can be highly selective um, angiography of the splenic artery when we will see the division of the main trunk into the regional arteries, and we can make embolization of the proper artery to arrest the bleeding. Of course, after some period of time, it will be infarction of the part of the spleen, infarction of the part of the spleen, and that is how we will arrest the bleeding and give the patient time, and the spleen will be in place, will be left in place. Surgery, conventional surgery. Decision to perform splenectomy or splenography is usually made after assessment and grading the splenic injury, using CT or even angiography, if we will, or maybe the indication will be ineffective angiography. Sometimes it happens. I mean, the embolization. So the splenography. Uh, Here you can see the amentorrhaphy. Using amentum, we cover the spleen with the part of amentum and fix it to the capsula. And here you can see the ligation of spleen using the long traps of the ligatures and using such a device to slightly to hold the ligatures and move from the skin. In here, we cannot leave such a spleen in place without any suture. If the patient will have the rupture of the one pole of the spleen, the resection of spleen is also possible. Here you can see the splenectomy. It starts from incision, as we mentioned. This incision should be midline. After that, we divide the gastrosplenic ligament and search for splenic pedicle. The orienter for us is the pancreatic gland, which tail in many cases comes closely to the splenic hilum. Okay, when we see the splenic pedicle, we can make a ligation. Usually, we use the ligation by hand suturing, and we use the three ligatures. Two, like here you can see, but this is the clips, I'm sorry. The same will be here and here. Then we will make a clamping, cutting, and that's all. With such a clamp, we will remove the spleen from abdominal cavity. Okay, so here I think so. This part shows the laparoscopic procedure, and the splenic pedicle is cut by endogeal device. It is a stapling machine, stapling device. It gives more reliable hemostasis in such a case, and it's easy and uh, uh, more quick than to ligate it by hands. Okay, post-splenectomy and splenography complications. They can be early, they can be delayed. The early is the bleeding, the acute gastric distension, gastric necrosis, recurrent splenic bed bleeding, pancreatitis, subphrenic abscess. So, the bleeding we discussed. So we need to make a reliable sutures to prevent the bleeding. Acute gastric distension is due to devascularization of the greater curvature. It can be treated by the make a drainage of gastric tube insertion, and uh, it will be the quick effect of this draining, and the patient will have empty stomach for a few days. Then we will start to feed him. Gastric necrosis, the same situation. Recurrent splenic bed bleeding due to not reliable arresting of bleeding. Nowadays, in our clinic and university, we use the LigaSure device, and the bleeding in many cases doesn't occur, even after big operations. Pancreatitis, it happens due to damage of the pancreatic tail, which is very close to the hilum of spleen. That's why sparring of this, salvation of this spot is very important, to see the tail and not to touch it using instruments, hands, and so on. And some phrenic abscess happens rather early, especially if the patient was treated not immediately after an accident, but the road to the hospital took lots of time, and the intra-abdominal blood was infected. So it's not easy to treat such a patient. Besides, of course, we use the antibiotics, but in some cases they are ineffective because in this post-splenectomy period of time of the patient, the nosocomial flora takes place, and that's why our antibiotics can be ineffective. Okay, late complication, thrombocytosis. So the sepsis, overwhelming sepsis, it will be in 1 to 6 weeks, and deep vein thrombosis, it is also possible. And besides that, if we make a ligation of splenic vein, or for example there was the damage of splenic vein, or maybe some hematoma formation along the splenic vein, and it was the blood supply or blood outflow from the spleen was damaged for some period of time, or maybe we made some mistakes during the operation due to some severe injury of retroperitoneal space, and we lost the vein, the splenic vein. I mean lost. We cannot assess it completely inside in the operating room. and sometimes the blood clots are inside the vein, and when for example, the blood outflow from the pancreas and from the inferior mesenteric vein goes inside the splenic vein, and sometimes the blood clots forms inside the vein, and after that, due to our normal anatomy, this clot will go to portal vein, and the portal vein thrombosis will be present. It's a very severe situation. It takes not often, but sometimes it happens. And this we need to remember and to control after surgery using our ultrasound. If we will see this, we can apply thrombolysis, because the complications of the portal vein thrombosis are very severe. Okay, splenosis, post-traumatic implantation of spleen tissue. In most cases, the accessory spleen are in the singular, but there are a few spleen up to 5 or more. They are usually located in port of spleen and tail of pancreas. Why it happens? Because some parts of spleen are ruptures of the main spleen tissue and goes inside the fat, sometimes in omentum, and they implants in this tissue. The new vessels comes inside these small parts of spleen, and the blood supply will restore. And these small spleens, they will work as a normal spleen. Not in many cases. It will not take place in 100%, but still they will have some function. It will not be enough comparing with normal spleen, but still such a process takes place. You can remember this. Okay, thanks for watching, thanks for attendance of our lecture. Good luck. See you next Monday at the same time and the same auditorium.